specific groups or specific conditions. And I'm not critiquing those, but I'm just kind of using those to as a contrast for the approach we've taken, really, which is kind of targeted at a slightly different question, I guess. So kind of the red boxes there are those case studies. So we call them prospective. So they've selected in advance a single group or condition and then observed experiences and outcomes for that group or condition. We're kind of coming at it the other way around, if you like, retrospectively. So what we want to do is observe patterns in global outcomes or patterns for the entire population in terms of their use of emergency care. And what we're hoping is that by kind of careful analysis of those patterns, the data will reveal which groups or which conditions have been particularly affected, and kind of we're not forced to pick in advance or select in advance. The idea is that the data will tell us, and it might be different groups or it might be the same groups as other people have kind of picked up in case studies. But clearly there are some challenges in doing that. So I've said we want to look at patterns of use of emergency care services, but we know that they were also heavily disrupted during the pandemic. So on the chart here, we've got time series for ED visits, time series for unplanned admissions, and on the right-hand side from 2020 onwards, bed occupancy for patients being treated for COVID-19. So you can see the big dips in emergency care activity coincided when lots of beds were occupied by COVID patients. So there's kind of no perfect answer here, but what we were looking for was to compare activity across two time periods. We wanted a time period later on in the pandemic, ideally where activity levels had recovered somewhere close to what was usual before the pandemic. We needed a time period of reasonable length to give us kind of a large enough sample size of activity to look at. We wanted that time period, assuming it was less than 12 months, to match the time period that we were looking at before the pandemic, and we wanted it ideally where kind of there was capacity to treat problems other than COVID, so not coinciding with any of the various waves of the pandemic. So what we've come up with is we're going to look at or compare activity in the kind of the two shaded blocks here. So we've got weeks 25 to 43, so about a 20-week period through June through October, at the back end of second half of 2021, and we're going to compare that with the same period in 2019, so kind of immediately prior to the pandemic. And our thinking here is that any differences in the types of conditions that people are presenting within that second period compared to the first period should tell us something about the potential effects of missed care earlier in the pandemic, or kind of wider fallout from the pandemic in terms of the way it's affected population health or morbidity. So we're kind of the rest of the analysis that follows is based on a comparison of those two time periods. So this just gives you a little bit more detail about those two time periods and activity trends and levels within them. So it wasn't critical to our approach that the absolute levels of activity were identical or very similar, but it does kind of make things a bit easier that actually the activity levels both for ED visits and emergency admissions were pretty similar in terms of the absolute levels during those two time periods. And so what we went on to do was to use statistical process control methods to compare the mix of individual diagnoses across those two time periods. So did particular diagnoses or presenting conditions increase significantly in that later time period compared to pre-pandemic? And so kind of the first step or kind of the first output from that analysis that then becomes a really rather long list of individual diagnoses that increased. So this is looking specifically at diagnoses or presenting conditions in emergency departments and picking out the ones that increased most in that later period. So the red bars are the absolute values of the number of visits in a second period, so in 2021, and the orange bars are the scale of increase in 2021 from the same period in 2019. So a figure of 2 would mean a doubling, a figure of 3 would mean a tripling, and kind of they're ordered by the scale of increase there. And kind of these were kind of really interesting, and kind of you immediately start picking out individual conditions and hypothesizing about why some of these things may have increased. And obviously some of them are kind of directly related to COVID. So if you think about the one at the top of the list there, SARS, then that's a COVID related diagnosis. And also I think in there we've got yes, post-viral fatigue syndrome was the one I was looking for. So that's kind of about 5 or 6 down, a tripling for that particular presenting condition, and kind of, probably suspecting that that's perhaps related to long COVID. But you've got a whole host of other things in there, radiculopathy, so that's kind of pinched nerve in the spine. Eating disorders is a prominent one that I'll come back to. You've got quite a few pediatric related conditions, hand, foot and mouth, bronchiolitis, all those sorts of things. And I'll kind of come back to why that was the case shortly as well. So but that's CD, and obviously I kind of only picked out the top 20 or so here, but we've got a much longer list. And this is similar for unplanned admissions. So for unplanned admissions, we're looking at 4-character ICD-10 code. So we're going down to quite a granular level of detail. And again, you can see there are lots of kind of COVID related diagnoses in here, but also kind of common infections of childhood. So RSV, bronchiolitis appears quite a lot. I think eating disorders is in this list as well, kind of about 3/4 of the way down. So I think we ended up with about a couple of hundred diagnoses in ED and maybe 400 plus for inpatient activity, where the scale of increase was significantly greater than the overall change, and the SPC methods were kind of suggesting that these were the ones that kind of warranted kind of further attention, if you like. So although these long lists were kind of interesting and you could kind of spend a lot of time going through them, we didn't think that they really kind of provided a useful basis for kind of decision making or taking action. So the next step from here was really to try and turn this long list of diagnoses into something that was more useful. So what we did was we conducted a grouping or clustering exercise to go through these lists and try and work out whether there were sensible, kind of clinically meaningful groups of diagnoses that we could kind of group together to kind of make kind of our findings kind of a bit more informative and kind of a bit more useful in terms of a basis for decision making. So kind of we had a group of people, various backgrounds, come together and kind of go through that long list and come up with some groupings, and I'll share those groupings with you in a moment. But I think it's important to kind of just remember that with kind of any grouping or clustering exercise, it's an inherently kind of subjective or judgmental task. There isn't a right grouping. There are lots of plausible or possible groupings that you could come up with, and you know, people could make kind of perfectly rational arguments for kind of slightly different groupings than the ones we have, and obviously for any, you know, individual condition, for some it's kind of, you know, most people would make the same judgment about which group it should be in, but for others it's kind of much more difficult, and they kind of almost perhaps sit between a couple of groups or don't fit naturally into any single group. But on balance, we think that the groups we've got are kind of a much more kind of useful takeaway than the alternative, which would be to kind of leave it at these very long lists. So we've got 12 groups here, and these are the groups of patients or conditions that we're kind of suggesting on the basis of patterns of emergency care use. We think they were kind of adversely affected by either missed care or wider fallout from the pandemic. So we've got things like eating disorders, we've got common infections of childhood, back problems, a kind of group of other childhood conditions. We've got either a mix of, or two groups, one that's more late presentation of a long-term or chronic condition, and one that's more likely, we think, to be an exacerbation or complication of a pre-existing chronic condition. We've got the effects of alcohol misuse, complications related to pregnancy, physical injury, where we think, but we can't be certain, that there's a link perhaps to physical violence, social isolation, particularly among older people, and a group that's related to kind of follow-up from surgery or post-operative problems. I've ordered those groups in terms of the scale of increase in ED visits, but obviously there are kind of, I'll kind of pick out a few of those groups in a bit more detail, but there are kind of different ways of viewing, thinking about which is kind of perhaps the most serious, or which groups kind of you might want to prioritize for further action, because obviously clearly 12 groups is a lot, and there is probably some kind of prioritization or assessment of perhaps, I guess, whether we think that some of these are going to continue to be problems into the future, or whether some of them are more transitory in nature and might kind of naturally just disappear or become a smaller problem. So in the full report that I've kind of said will be out at some point within the next couple of weeks, what we've done then is we've kind of got a profile that kind of digs into the detail for each of these 12 groups, and that includes kind of some of the detailed specifics around the data that we found, but also drawing on wider evidence about other sources of information for some of these things and what's been found in other countries, and kind of do our findings correlate? How certain are we about kind of the underlying mechanisms or that we think perhaps have caused these changes that we've observed. So I'm just going to pick out a couple that I think are interesting. Obviously, we probably haven't got time to go through them all, but perhaps if I pick out a couple, and then perhaps if we kind of move on to questions, and then if there are particular groups that people are interested in, I'll try and tell you a little bit more about exactly what we found for those groups. Yeah, so this is just a bit more detailed, a few examples of the sorts of conditions that appeared for those different groups. So I'll skip over that for now. Maybe we'll come back to it during questions. So this is one of the groups. So what I said, one of the groups was common infections of childhood. So there's a whole host of kind of viral infections that kids normally pick up at a relatively young age, and a certain number of those end up presenting in emergency departments or admitted to hospital because they have specific problems with those conditions. And you can see the time series in the top right. This is very seasonal. There's a very strong seasonal pattern to this sort of activity, and although the size of the peaks might vary slightly from year to year, the timing of the peaks is always fairly consistent around kind of the winter period when those viruses naturally are circulating more. So you can see in 2019 and 2020, there's kind of a really stable seasonal pattern to admissions for this group of diagnoses. And then if you look at 2021, you can see, well, actually there were very, very small number of admissions for this group of diagnoses. And so, what was going on there was kind of all the things that we were doing to prevent the spread of COVID had the side effect that they also prevented the spread of other viral infections. So, influenza or flu is the one that people often talk about, but it also had an effect for all these kind of viruses that circulate among children. And then obviously what happened later on at the back end of 2021, when we were coming out of lockdown and society opened up and people were mixing much more and were perhaps a bit more kind of lax in some of those actions that we were all taking, things like hand washing, masking to prevent the spread of coronavirus. When we stopped doing that, kind of all these childhood viral infections suddenly started spreading, and what we got was, although the peak was the height of the peak was lower than in previous years, it came earlier, and it was kind of perhaps a longer, flatter peak. So we, and this is kind of something that's been reported, similar patterns across lots of countries. So we've got a pretty good understanding, we think, of exactly what was going on here at this time. We're perhaps a little bit less certain about what will happen next for some of these conditions. Perhaps it's going to take a little while, a couple of years before we revert before they fully revert to kind of the normal, what we think of as kind of the normal seasonal pattern that we saw pre-pandemic. And obviously that's kind of a little bit dependent on obviously what happens with coronavirus and COVID itself going forward. But perhaps some suggestion that kind of this effect kind of might moderate and become be a transitory effect, if you like. So that was a group of common infections of childhood. This is a little bit different. So alcohol was an interesting one, I think, because until relatively recently, I think a lot of people were struggling to work out what the effect of the pandemic and our response to it would be on alcohol consumption. So clearly the interventions that we made and our responses included a lot of things that affected people's ability to buy alcohol. If you think about pub closures and restaurant closures, and people were doing a lot of work to try and understand what that actually meant. If people couldn't buy alcohol in the pubs, were they just buying more from the supermarkets and consuming it at home? And kind of what did that mean for different groups in society? And I think from what I've seen, it's now becoming a bit clearer, at least in our country, that actually perhaps the trends in alcohol misuse were worsening slightly before COVID, but COVID certainly seems to have either kind of sped up the worsening of those changes, or kind of also or made some sort of step change in the levels of alcohol harm, and that's kind of corroborated by a number of different sources. So there are figures on the number of alcohol-related deaths since COVID. So I think in 2020 and now the figures for 2021 are almost out. The number of alcohol-related deaths has increased steeply in both those years, a real kind of step change from levels that were fairly flat pre-pandemic. And what we think is going on perhaps is that particular groups in society have been affected by the pandemic. So we've got here a chart which shows the percentage of adults drinking at risky levels. So this is from a population-based survey, the Alcohol Toolkit study, which surveys kind of a representative sample of the population on a monthly basis, and people self-report their levels of alcohol use. And they have these two measures, audit and audit C. One's a kind of a wider measure, one's a more specific measure, but what they're trying to track is levels of it's kind of a screening tool for drinking at harmful alcohol levels. And you can see that those levels jumped at the start of the pandemic, and they've kind of stayed at kind of a higher level, really, and that's kind of continued even now into 2022. So this is kind of quite worrying, because the effects of alcohol misuse on people's health and their utilisation of a whole range of healthcare services are fairly long lasting. These are things that are not going to be transitory, perhaps in the way that the group of childhood infections might be that we looked at previously. So that's kind of effects of alcohol misuse. So I've picked out a couple just because I thought they were kind of slightly different and interesting. But I'm gonna stop there, I think, and kind of just see whether we've got any questions, or whether people want to ask me about some of the other groups, or yeah, just interested to hear general feedback or thoughts or comments as well. So thank you.
Thanks, Paul. That's really interesting. I have a couple of points and a couple of questions which have been raised on Menti. So I'm just going to, instead of sharing my screen, I'm going to read a couple out, and I'll read them out in the order that they appeared. So they might have been relevant to before in the presentation, but let's see what we've got. So the first point was by somebody who is a more general point about this person is keen to link in with anyone looking at system demand and capacity planning assumptions. So I would like that person eventually to reveal themselves, and we'll see if we can make some connections there. Second point was it states, is the change in condition activity for unplanned emergency admissions perhaps a more complete gauge of unmet need, as the ED data could be skewed by access and perceptions around access to primary care? I feel like I should actually have shared the screen now, because I probably need to read that again. I am actually going to share my screen because I may not do some of these things justice. So it's this one in the middle here.
Yeah. Yeah, so I think that's a really good point, firstly. So there are a couple of issues, I guess, with the ED data that would perhaps lean me to or kind of our view kind of being that perhaps the data on unplanned admissions is a little bit more useful or a little bit more reliable. So obviously with ED data, I guess a lot of you will be aware about there are issues in terms of the completeness of diagnosis coding. So not all, although that's improved over time, not all trusts code all their ED activity. Some are better than others. And so we did try to account for that. So our ED analysis is based on a subset of providers that we checked coded their activity, or coded a high proportion of their activity over that entire period. That subset, or that sample, is pretty large, so we think it's representative of what was going on nationally. But obviously ultimately it is a sample, whereas the data on unplanned admissions is kind of the full population of trusts across the entire country. So that's one thing, and yes, people's use of ED will be, I think, affected by either real difficulties in accessing primary care or perceived difficulties in accessing primary care. And so yeah, so there are potentially groups of people that are not or presenting in ED because yes, I guess that relationship might change across the period that we're looking at. Yeah, so I think that's something that, yeah.
Okay. I mean, you can see you can only look at using the data that you have. You have to make these assumptions, but you can't measure everything all at once, can you? You just have to be aware of these different relationships. I mean, this seems quite a common sort of a perception.
So we focused on the diagnoses where the frequency of people attending is increased. But if you look at the other end, if you look at the sorts of things that people weren't attending for in that later time period that they were pre-pandemic, then it tended to be, this is kind of a bit of a generalization, but it tended to look like the less serious end of the spectrum, which would kind of fit with, I guess, with the idea. Well, no, perhaps it doesn't necessarily fit with that, but it tells us something about people's perceptions of whether they should, or their decision making about whether or not to attend a particular service or point of delivery with a condition during the pandemic, and people's kind of perceptions around the risk of kind of the risk reward balance of that probably changed, I think.
Okay, yeah. Okay, so let's just move on to just a couple more points here, a couple more questions. Just one here saying whether, from your perspective, were there any results which were particularly surprising to you, or not?
Gosh, that's a good question. I'm trying to think back now to when we kind of first started looking through some of those diagnoses. Yes, I guess kind of surprising suggests that I kind of perhaps had some preconceived ideas about what we would find, and I don't think, bar kind of a few fairly obvious examples, I did. So so certainly things, for example, around the post-operative problems that we've picked up. I wouldn't necessarily have expected that, or have thought of that as being a group that were affected. Yeah, so I mean, yeah, there were several groups, I guess, that I don't think I would have been able to predict beforehand. So, for example, exacerbations of or complications relating to long-term conditions. So the fact that people were turning up with complications of diabetes and things like that wasn't particularly surprising to me, I guess.
Yeah. Yeah, sure. Okay, so there's just this last point here. Would it be useful to also look at the impact of COVID on planned care routes, e.g. ERS referral rates by clinic type, specialty, and also additions to inpatient waiting list? These could be conditions that commenced or worsened across the pandemic. So some further areas for investigation. What are your thoughts on that?
Yeah, I mean, so lots of kind of other people are kind of looking at this question, aren't they? We know waiting lists have increased a lot. So one of the things that we did pick up was in this kind of post-operative problems group, where we had a lot of kind of urology or gynecology or issues relating to surgery in those two specialties. And I think I'm right in saying that those two specialties have seen particular kind of increases in their waiting lists across the time we're looking at. So yeah, so yeah, absolutely, it's an important question. Kind of, I guess, not the focus of this piece of work, but something that's important for people to look at.
Okay, so that's it for the questions that we've had. I've just actually, it's not true. In fact, just one more. So here, so the request for linking with demand capacity planning assumptions, we now have a name. There we go. That's excellent. We'll follow up on that. That's really good to hear. I like to do the for us to connect with one another.
Stephen, you've got your hand up. Was that related to the question that was just asked, or?
Just going back a few over the questions, there's a sort of common theme to the two questions I think you were picking up. So when we were designing the project, clearly what we're trying to do is get advanced warning of problems that are emerging that the health service might be able to or might need to respond to. We could get a definitive answer by waiting 20 years and seeing what the mortality rates and how those have changed, but then by then it'd be too late to do anything about it. So the reason we're looking at urgent care is because we thought there was a good chance that the consequences of reduced access to care during the pandemic would play out in increased emergency admissions and ED attendances in the reasonably short term. Emergency admissions, I'm with Paul and the commentator that's a better marker, but it's probably slightly later on the pathway. And that EDs is at a lower threshold, even if it's a noisier signal, it might still give us a bit of advance warning over things that haven't yet played out, deteriorations in health conditions that warrant admission yet. And I think the waiting list is another step on from that. Yeah, if things that end up on waiting lists will probably have gone through a certain further set of deteriorations. such that people will go to their GP and get referred onto the list. So I think they're all good markers, but they give us different views on the stage on which the problem has progressed. But at the point when we were planning the project, we thought the best markers to get a handle on this was emergency admissions and ED attendances. As time passes, yes, looking at changes in referral rates onto waiting lists will be another really useful perspective on the problem.
Okay, thanks, Stephen. So I suppose the next thing is before we let you go, Paul, is what happens next? What do you think these findings, this report, how's this going to be used? How's it going to have an impact?
Yeah, so so in the report itself, we make a number of kind of recommendations associated with each of these groups. So I think they're kind. This was a national level analysis.
Yeah.
I think our kind of default assumption would be that if we've picked up a signal in national level data for these groups, that signal will probably also exist at a regional level.
Yeah.
But obviously the particular context for individual ICBs is important, and kind of any decision making around exactly what actions they take in terms of responding to perhaps identified need in each of these groups needs to kind of be based on their particular circumstances, which will obviously be somewhat different. So I guess what I'm saying is we've kind of had a kind of first pass at things we think they might want to consider, but obviously there are other kind of sources of evidence and kind of regional context that kind of needs to be drawn into that. So what we're looking to do is the full report will be out some point within the next fortnight, and obviously then we'll look to kind of arrange sessions with individual ICBs to kind of go through those or kind of particular aspects of the findings, and kind of and take it from there really.
Okay.
I don't know whether Simon, did you want to come in and say anything more on that?
Yeah, sure. I mean, I think just to build on what you've said there, really is this is a starting point. It suggests areas for further investigation that systems will look to, they'll look to corroborate it with their various other sort of local sources of evidence from their leading clinicians or other analysis that they've done. So we offer this up as a starting point and suggest systems use it as an input into a reflective process and start reflecting on whether they need to take some early action to prevent some of the downstream problems that we're starting to predict here.
And linking into Fergus's question, I do think maybe those thinking about, in the beginning of their winter planning exercises is probably not a bad place to look just for some pointers and tips on groups that you might see extra demand for this year that maybe you wouldn't have normally anticipated.
Okay. Well, thanks very much for that. Thank you, Paul. Thanks for your contribution as well, Stephen and Simon. We're drawing to a close, but before I do, I'm going to be just sharing with everybody my screen again, in fact, just so I can just remind folk what we've got coming up in the next couple of huddles. So we're going to be not necessarily in this order, but we're going to be talking more about health inequalities, and I'd like to get a group of people together to represent different angles of health inequalities, as we have done in the past. We're going to be talking more about reproducible analytical pipelines because everybody just wants to know more about that. We feel we need to know, and now we can share that information with you. And we're going to be hearing about the health of the English regions reports as well. So that's going to be, those are coming up, and there's a lot more, but those are the ones in the next few weeks. And I really want to draw your attention as well to the up and coming training and development registrations, which these ones are currently open. So next week we've got a 2-hour session, which is an introduction to health economics and evaluation. So that's for non-technical. Anybody who wants to know more about health economics and evaluation, do go along to that, register for that. There are spaces on that. Then we have more significant training courses. We've got the healthcare science and operations research course, which is starting in November, and that's 10 half days. So you can register for that and find out more about that on the website. And we've got leadership development for analysts, one of our flagship courses, very popular, very successful. We have 2 iterations of that. The first one is online and is starting in November, early December, sorry. So do register for that. And introduction to machine learning, again, this is another more of the substantial one starting in December. So there's quite a lot coming up. Do check the website for all of the information. The prospectus is a good place to start because it has it all in one place. And of course, what you don't want to be doing is not registering for Insight 2022. So please do register for Insight 2022. You can register for individual events. If you keep registered for the whole festival, we can let you know about new events because there's 1 or 2 that we haven't shared with you yet, and that's very exciting. So back in the room. Thanks again, everybody, for coming. Thank you, Paul. And we'll see you in a couple of weeks. And in a couple of weeks, or it's 4 weeks from now, it's the NHSR Community Conference, and I'm going to try and do this huddle from there. So that's going to be fun. And meanwhile, I'm just going to finish this session. I'm going to couple together this recording, and it's going to look great, and it'll be on the website in a day or so. Thanks, everybody. See you soon. Bye.